Today, we'll be watching a clinical overview of the Frenchay Activities Index and the Klein ADL scale. We will first begin with the objectives of the presentation. We seek to demonstrate how to administer the Frenchay Activities Index and the Klein ADL scale. You will see an overview of psychometrics and potential biases of these assessments. You will also see a description of purpose, length of administration time, and intended population/age group for each assessment. You will also receive an explanation of scoring measures and scoring interpretation for both mentioned assessments. Starting off with the Frenchay Activities Index. This looks at different categories of ADLs, IADLs, and activities. It asks the client how often they've done them in the past 3 or 6 months, with 3 months being the first category of ADLs, IADLs, and activities, and then 6 months being the second category. The goal is to look at participation in daily activities. This is a questionnaire filled out by the client and it is criterion referenced. The age is 25 and above, and the time to administer takes 5 to 10 minutes. It's mainly for populations with people recovering from stroke. However, studies are being done on other populations as well. This is an example of the questionnaire filled out by client Jane Doe, who writes her numerical answers next to the questions. On the back of the sheet is an explanation to help the clinician specify questions if the client has any question. So for example, going back to number 1, preparing main meals, if you flip to the back, it reads that you need a substantial part in the organization, preparation, and cooking of the main meal, not just heating things in the microwave or reheating prepared food. So this helps improve the specificness of the questions. Now we'll look at the administration. For position, the client and clinician can both be seated at a table. All they need is a room where they can have a discussion. You only need the piece of paper and a pencil. The type of administration, like I said, is a written questionnaire, so the clinician will go through questions with the client as they fill in their answer. Under special circumstances, if the client cannot read or write, the clinician can read the questions to them, and then the client can say their answer, which the clinician will record. If the patient is unable to cognitively or physically verbalize their answer, the creators of this test said that it's okay for clinicians to ask their caregivers and then record their responses. This is a following video of the administration. Today you will be watching the Frenchay Activities Index be administered to a client 5 months post-stroke. The materials needed are a pencil, the questionnaire, and a setting the client and clinician can sit down and engage in conversation in. The test is divided into 2 categories. The first category asks about what clients have engaged in the past 3 months. Items 1 and 2, preparing and cleaning up after meals, are rated 0 for never, 1 for less than once a week, 2 for 1 to 2 times per week, and 3 for most days. Items 3 through 10 address clothes, light and heavy housework, shopping, social outings, walking outside, actively pursuing a hobby, and driving or riding a bus. These items are rated 0 for never, 1 for 1 to 2 times in the past 3 months, 2 for 3 to 12 times in 6 months, and 3 for at least doing these things weekly. The clinician reads through these with the client who writes down their answers. The second category asks about what the client has engaged in during the past 6 months instead of 3. Items 11 through 15 address traveling, gardening, household maintenance, reading books, and gainful work, which is further explained in the Frenchay Activities Index Guide as work that is paid, not volunteer work. Travel and gardening are also answered with a frequency of engagement, like the items from the above first category. Household maintenance is measured based on the intensity of work, with 1 being light work and 3 being heavy work. Reading books is based on the number of books read in either the past weeks or months. Gainful work is based on the hours the client spends working a week, with 0 being no hours and currently not working, and 3 being over 30 hours a week. Scores are added up by the clinician after the test is administered. The higher the score, the higher a client's participation is in ADLs, IADLs, and activities. Today you will be watching the Frenchay Activities. So that was just a quick overview of the demonstration, and now we will move into the psychometrics. First off, with reliability, This was rated in multiple studies as good to excellent. Researchers found consistent to identify activity function. With inter-rater reliability, this was also rated good to excellent. This is specifically looked at in stroke studies. Predictive reliability, which is the ability of the assessment to predict future outcomes, was also rated good. Validity, however, was rated poor to adequate, and there were a lot of studies I saw that brought this into question. There were some ambiguous results, which I'll talk about more, but basically, some patients were not familiar with some of the listed activities before their stroke, so the resulting scores that they ended up with were skewed. Scoring and normative information. Like I mentioned before, this is not norm reference, it's criterion reference, so it's really just measuring the client against themselves. However, you can use their scores as a baseline. If you start this at the beginning of your treatment and then reevaluate them maybe 4 weeks in or at their discharge, you can measure their progress. Scoring is generally rated 0 to 3, like you saw in the video. 0 being no performance of the activity at all, and 3 normally being the highest amount of times that they can perform the activity. The added up scores are looked at in the total scoring overview. If they only score 0 to 15 total, it's inactive. If they score 16 to 30, they're moderately active. And then 31 to 45 is very active. Next, we'll look at clinical utility. This assessment is great to use on stroke patients, but it's also applicable for any sudden change in condition that alters your immediate ability to complete ADLs. For example, this would be appropriate to use on a client who got in a motor vehicle accident and sustained a spinal cord injury. This assessment is utilized by occupational therapists to help give a baseline of their clients' ADLs and IADLs, and just different capabilities of what areas need improvement. This test, like I said, can also be re-administered in the beginning of end of treatment and at discharge to just measure client progress with their ADL and IADLs. However, even though this assessment does have some strong statistical evidence, there are some potential gaps in the research and biases. For example, like I mentioned before, there is compromised validity. So these patients who are not familiar with some activities will have their results skewed. For example, if you gave this assessment to a client who lived in a colder climate and who did not engage in gardening that much, they'd probably rate this as 0. However, it's not that they aren't physically able to do gardening, they just don't. And so this could make the results seem more dependent and less inactive in ADLs than they actually are. One study suggested to solve this problem would be to change the assessment and ask the client if they think that they would be able to perform the tasks, not if they've done them recently. There's also some observed gender biases. Some studies suggest making separate assessments for males and females because there's many cultural and gender specific tendencies to split chores. Like stereotypically, women tend to lean more into lighter housework and cooking and laundry, while men lean more towards heavier housework and household repairs. There is some cultural relevance of this test as well. It was successfully used in a stroke study in Italy, with a translated version of the test being administered. Next, we'll move on to the Klein-Bell ADL scale. Similar to the Frenchay, this measures a client's ability to complete ADLs. It has 6 ADL dimensions with 170 items total, and each ADL is scored individually. Unlike the Frenchay, however, this is an observational standardized evaluation and can be administered to populations of any age. The time to administer is 60 to 180 minutes, with an additional 15 minutes set aside to score. The intended population can be patients with disabilities or able-bodied patients. There are 6 key dimensions to this test: dressing, elimination, which is the ability to manage toileting needs, mobility, bathing, emergency communication like telephone use, and eating. An example that we pulled from dressing would be the prompt, put toe into left shoe. The clinician would guide the client with this prompt and then observe if they're able to do this. Also, just a note, this assessment is copyrighted and not owned by our institution, so I wasn't able to access any type of scoring sheet, but an example video will be provided. But under administration, we look at position. So the client and clinician are moving around their clinic or home environment. This can be seated or standing, kind of depending on the task. For type of administration, this is observational. The clinician will read off the prompts, like the dressing example, from each item to the client and just watches their performance. Clients are scored on their ability to complete the item. This is an example video of demonstration.
Is a 40-year-old male, status post to stroke, resulting in left-sided hemiplegia. All right, Mr. Dantier, today we're going to take a further look at your morning routine. So exactly what we're going to do, I just want to see what you kind of have trouble with and what's kind of easy for you to do in that morning routine. It's going to consist of getting up and out of bed, so from a bed to a chair, using the restroom, taking a bath, getting dressed, eating, and then we'll make a telephone call, and that'll be it. And I'll just be doing an observation, and we'll kind of look at and see what's easy and hard for you, all right? Perfect. At the start of the assessment, we are going to observe the client doing basic ADLs. For the purpose of this demonstration, we're going to observe Dantier dressing, toileting, and doing mobility. All right, Dantier, we can go ahead and navigate into the bathroom. You can use your walker and go ahead and open that door. As you can see, he's able to use his walker to navigate through the doorway. Open the door. All right, Dantier, you can go ahead and sit on the toilet, and we are going to just pretend to do the... Oh, you all right? Yes. All right, let's go ahead and reach for the toilet paper. And then go ahead and rip a piece off as you would. Perfect. And then you can just pretend to wipe. Wonderful. And then flush the toilet. All right, let's go ahead and put your pants back on. All right, so now what the OT is doing is observing different components of dressing at this point. As you can see, he's having some difficulty with that. So now the OT could provide cueing. All right, Dantier, what might be easier is if you take your arm and lift up your left leg and place it over top of your right leg. Perfect. Now you can go ahead and put...
So this video of the administration is basically the OT observing the client and also cueing verbally if needed.
The PA is a 40-year-old male.
The psychometrics of this assessment are also important. The test-retest reliability was rated high. Repeated administrations of the Klein-Bell ADL scale resulted in consistent results. The inter-rater reliability was also rated high, as multiple clinicians produced similar results when this was looked at with stroke populations. Validity was also limited in research. There is a lack of testing on other populations such as the pediatrics or those with developmental disabilities like cerebral palsy. With sensitivity, this assessment was rated highly sensitive. The Klein-Bell ADL scale is very sensitive to small changes in client function regarding ADLs, which makes it a good indicator of client progress. Like I said before, this is not norm referenced, it's also criterion referenced, and similar to the Frenchay, you can use the client's scores as a baseline by administering this test multiple times throughout treatment. The individual item scoring is as follows. 0 cannot complete the item. 1 can complete the item with assistance, so like those verbal cues that she was giving in the video, or physical cues, or physical assist. And then 2 can complete each item independently. Similar to the Frenchay, their scores are added up into the total scoring overview. 0 to 49 indicates a significant level of dependence. 50 to 99 suggests a moderate level of dependence. 100 to 139 suggests a moderate level of independence. And 140 to 170 is a high level of independence and is where we would like clients to be, ideally. There are also some potential biases and gaps in the research for the Klein-Bell ADL scale as well. There is a significant age bias as there's limited validity with pediatrics. The scale and the creators of the scale say it is applicable to all ages, But with some of these categories, like tying shoes under dressing or emergency cell phone use, this may not be applicable for younger clients. For example, if you're administering this to a 2-year-old client, you're not going to expect them to be able to tie shoes. There is also a significant cultural bias, especially in the dressing category. Some cultures do not wear pants and only skirts. Some wear hijabs or head coverings. Some, like in Hawaii, people culturally don't wear shoes. Basically, not everyone dresses to the same standard, and they would get points deducted for not dressing to the standard of the Klein ADL scale, which is a typical American standard of dressing. Here are the discussion questions. Number 1. The Frenchay Activities Index is primarily a questionnaire used to ask clients about their own perception of abilities. For clients with cognitive impairments who were unable to complete the writing or fully understand the questions, how would you as a clinician modify the test? The Klein-Bell ADL scale has categories such as emergency telephone use that are not addressable for younger pediatric clients. What kinds of dimensions would you possibly include to modify the test for younger clients? Since both of these assessments examine daily participation in ADLs, IADLs, and more, there is debate of cultural and gender differences across populations. These factors bring the validity of both of these tests into question. Can you think of any other instances where there will be differences across demographics? And finally, both assessments examine specific function and activities of daily living. How can you as a clinician utilize these assessments when measuring client progress? These are the references I used for this project. Thank you so much for listening.